Wessex Local Medical Committees, Education and Training. A quick update in less than 10 minutes for clinicians working in primary care. Wessex LMC supporting you and your practice. This update is the second of a series looking at cancer. In this update, we're going to look at screening, prevention and risk factors. If we want to improve survival rates from cancer, then we need to do a number of things. We need to focus on prevention, screening, better access to diagnostics, the development of the rapid diagnostic services, and also make better treatments available. There are currently 3 national screening programs for the detection of cancer, and these are breast, bowel, and cervical. In the UK, women are offered breast screening every 3 years between the ages of 50 and 70. Screening saves about 1 life from breast cancer for every 200 women who are screened. This adds up to about 1,300 lives saved from breast cancer each year in the UK, or about 3 women saved every time the screening van visits your primary care network area. Nationally, the target for uptake is 80%, and we're only currently achieving 72%, although in the Wessex area we're faring slightly better at 74%. But we know there are some areas that are hard to reach and populations where the uptake is significantly lower than the national average. If we wish to increase the uptake of breast screening, then this can be done and has been done successfully in some areas using social media, especially via women's group and practice Facebook accounts. It would also be helpful when the breast screening unit is coming to your practice area to promote this via your practice website, perhaps an article in your practice newsletter, and on your practice notice board. Bowel screening is offered every 2 years to people aged between 60 and 74. In addition, a flexible sigmoidoscopy is being offered to people at the age of 55. Bowel cancer is the 4th most common cancer, and it's estimated that the NHS bowel screening programme could save between 1,800 and 2,400 lives each year in England by 2025. The target uptake nationally is 60%, which is currently being achieved, although in Wessex the percentage uptake is slightly better at 65%. We know we could increase the uptake to more than 65%. Currently, the invitation letters come from the NHS. If a reminder letter was sent on behalf of practice and personalised, this has been shown to increase the uptake. We also know that moving from FOBs or fecal occult bloods to the new FIT test is far more acceptable to patients, and hopefully this will also increase the uptake. Practices could promote this on their website, in their newsletters, and also via their Facebook pages. Cervical screening is offered to women between the ages of 25 to 49 every 3 years and 50 to 65 every 5 years. About 2,600 women are diagnosed with cervical cancer each year, and sadly about 690 women die from this largely preventable disease. The cervical screening rate has fallen to an all-time low, and in some areas it's as low as 50%. The introduction of HPV vaccination for girls aged 12 to 13 will eventually have a significant impact on the presentation of cervical cancer. And now with the introduction of HPV vaccination for boys, this benefit will be increased significantly. Nationally, the target for cervical screening is 80%, and currently we're only achieving 71%. Locally in Wessex, that figure is 74%. But the uptake by practice varies significantly. Practices have done a lot to encourage women to be screened, both by invitation and opportunistically. By offering more flexible times for appointments, for example in the evening and at weekends, this should increase the uptake and the availability of screening. For all screening, we need to look at our own populations and see if there are groups that are particularly reluctant to attend screening. This may be for cultural reasons or for lack of understanding. More work needs to be done to support practices in these areas. About 20,000 people present with lung cancer every year. Of those, 50% are at stage 4, and therefore it's not surprising that the survival rates are poor. The single factor that would reduce the incidence of lung cancer would be if more people were non-smokers and those who currently smoke stopped. Previously, there's been no screening programme for lung cancer, but a recent study in Manchester showed that 18% of people are diagnosed at stage 1 and about 48% at stage 4. After a trial of low radiation CT scanning, they diagnosed 68% at stage 1 and 11% at stage 4. There are therefore going to be 10 national projects looking at the lung cancer screening, one of which will be in Southampton, and £70 million is being invested to check those most at risk, inviting them in for an MOT of their lungs and on-the-spot CT scan. This will include mobile clinics working closer to where people live. We know that about 4 in 10 cancers can be prevented, and this is done by taking lifestyle actions such as stopping smoking, keeping a healthy weight, eating a diet with less processed food and one that's high in fibre, taking precautions in the sun, reducing the risk of infections such as HPV, drinking less alcohol, and being more active generally, and finally minimising the use of HRT. But it's no use just knowing what these lifestyle actions can do to change the outcomes for cancer. We have to find more effective ways of changing people's behaviour. Cancer in England is more common in people who live in deprived areas. There are around 15,000 more cancers in parts of England which can be directly related to socio-economic variation. We know that some cancers, for example breast, are less common in the affluent population, and this is thought to be due to increased screening in this group. The deprivation gap is greatest in the smoking-related cancers, which are more common in deprived areas. The incident rates for cancer are strongly related to age for most cancers, with the highest incident rates being in older people. In the UK in 2014 to 2016, on average, each year more than a third of new cases were in people aged 75 and over.
Genetics and cancer therapy is another massive area, whether we look at specific inherited cancers or an exciting new way of treating certain cancers. At a basic level, cancer is a genetic disease, as it is caused by changes to genes that control the way our cells function, especially how they grow and divide. Gene therapy is one way of treating or preventing disease by changing the genetic messaging in a single cell. Gene therapy could replace an abnormal gene which may be responsible for a cancer and replace it with a normal gene. Research in gene therapy for cancer is currently focused in multiple areas, including genetically engineering viruses that directly kill cancer cells, gene transfer to alter the abnormal functioning of cancer cells, and immunotherapy, which helps the immune system better find and kill cancer cells. This video was produced by Wessex LMCs. We hope you found it useful and informative, and that you'll use the information to reflect on, to add to your education portfolio and use for your revalidation. Wessex LMC supporting you and your practice. Thank you for listening.